me okay? Okay. I'm Ashley Harai with the Maternal and Child Health Bureau, and just want to welcome everyone here to the start of the 2016 MCHEPI Training course. We're almost all assembled. I think we have a few still arriving. We've all come from near and far. I'm glad most of us have made it. We have 3 local trainees here. Who's local? If they can raise their hands. Okay, great. So we have Haruna, Richard, and Navjot? Jimby? Jody, sorry. Great. And then I think the people that win the award for longest travel time are our territories. So we have 2 from Puerto Rico. Great. So Leslie Ann and Marianne. Great. And then Haley, who flew from Guam. Great to see you. Great. So just wanted to have a big thanks to Maureen Fitzgerald, a senior program coordinator for City Match, who's made sure we've all arrived here and have these excellent accommodations. It's a pretty cool hotel, right? So she's making sure we have everything we need to have a successful training this week. Maureen, did you want to have any remarks or housekeeping items?
Just a few housekeeping things. So first of all, I wanted to thank HRSA and CDC as well as City Match for facilitating this event. And thank you for being here. And thank you to all the faculty who put so much time and effort into making this a successful training every year. You're going to learn a lot this week, and in addition to that, you're going to be building relationships and networking. Take advantage of the technical assistance if you need it. In terms of logistics, I think Kristen will be talking a little bit about the Wi-Fi, but the Wi-Fi in this room is one word, all caps, City Match 2016. And just one final thing, last week I emailed each one of you to get an alternate email address, because at 1 year out, we will do a follow-up to see what your experiences have been since this training. And for those who didn't have a chance to send me that alternate email, I have a sheet, and I'll have it around, and you can come and just provide me with that email address. That's it. Welcome. Glad you're here.
Thanks. And Kristen, Dr. Rankin, just wanted to thank her for all of her work being the lead faculty in coordinating all of the content, rich content that you're going to hear this week. And I think, Kristen, you have some things to share about Google Docs.
Hi, I look forward to getting to know all of you this week. This is one of my most fun weeks of the year, so I'm really, really excited. We are going electronic this year. So I did send an email out within like the last hour with a link to a Google Drive. If you've had any trouble accessing that and you need a version, we have a flash drive that we can give to you as well. The materials for today and for tomorrow are posted. We're also going to use that to post extra things as they come up. Every year, something comes up as we're doing the training. Oh, we should share that. Oh, we should share that. So we'll just kind of keep populating it, but we'll let you know when it's updated. But for right now, Monday and Tuesday training materials should be there, so all the slides and the exercises. And if you don't have it, if you could raise your hand right now. Okay. Olivia, do you see who's raising their hand? So Olivia Sappenfield is here, who is a doctoral student of mine at UIC. I'm really happy that she's here this year, and she's going to be helping out with a lot of stuff and participating as well. So Olivia, do you want to just give a wave and say hi? So Olivia's going to help you get materials if you weren't able to get it on the drive. Okay, can you raise your hand high one more time so she can just see, and she'll just kind of float around and circulate and get you some materials, okay? All right, well, and the other thing was we did email you and say if you had any TA requests. So some of you signed up in advance for that. So tomorrow morning at the table, we're going to have a list of TA times, but you're also willing to do drop-in TA too. So that's if you have a project from your work that you brought with, or if you have a question, a lingering question from some of the lecture material that day. On Tuesday and Thursday, we'll be staying for an extra half hour and from 5 to 5:30 afterwards to do TA time. And we'll have more announcements about that tomorrow. Okay, so I look forward to getting started.
Thanks, Kristen. And also just wanted to thank Dr. Bill Sappenfield in the back of the room, who's going to be giving the first couple of lectures. He made it here despite being under the weather, and we really appreciate the extra effort. He has just a wealth of experience to share with you all. So yeah, we're just gonna have a great week together. It's pretty intense, and it is like an adult summer camp, which is it's kind of a rare opportunity that we get a week away from work to really focus on our development, and that's just a reminder of some of the tools and tips to get the most out of the course is really to really use this time to focus on your development. And there are break times and times at night that you can definitely check in with your continuing work responsibilities, but really try to use this gift of a week to really focus on yourself. Some other tips would be just really using that peer-to-peer exchange opportunity. We hear so much every year how valuable it is to meet one another working on similar programs and data sets to share those tools and tips. And so during breaks, tonight we have a reception for networking, and during lunch as well, we'll have different tables set up by kind of topic area and program for you to get to know one another. And I think Wednesday we're also going to try to schedule a group outing at a local restaurant for everyone. So yeah, it also just try to ask questions as you feel free. It really will help your own learning as well as the learning of those around you. So I think for now, we're gonna really just start with the introductions and getting to know one another. So if you can go around and just say your name, your employer, a little bit about your job responsibilities, and maybe an interesting fact that could be a conversation starter, a hobby, something you're looking forward to here in San Diego, what you might do if you were in public health, something interesting so that we can get to know each other and yeah, start the conversation. So I'll just start. I'm Ashley. I'm a health scientist at the Maternal and Child Health Bureau. I mostly provide data and analytics support to the block grant transformation, the infant mortality coin, and the Healthy Start evaluation, and also have oversight of this annual training course. An interesting fact, I guess, this past year has had a few major life events. In September, I moved across the country from Maryland to Portland, Oregon, and I can vouch that West is truly best out here with the great climate, progressive, active culture. And I'm also expecting my first child, so really learning a lot firsthand about MCH. Just bear with me if I have some pregnancy brain during the week. But so we'll, I guess, start over here.
Sure. Hi, everyone. It's lovely to meet you all. I'm Olivia Sappenfield. I'm sure you've gotten a couple of emails from me, maybe, or at least my contact info. I am a PhD candidate in maternal and child health epidemiology at UIC, working with and for Dr. Kristen Rankin. And a fun fact, I like to rock climb. It's what I do in my free time. And I'm very disappointed because San Diego is very close to Joshua Tree, which is some of the best bouldering in the US. And none of my climber friends could make it.
Hi everyone, I'm Hannah Kim from Rhode Island, East Coast. So it was it's a long trip from East Coast to West Coast. Yes, I arrived here yesterday night. And I am an epidemiologist for the Rhode Island Department of Health. Basically, I work for the PREMS data and immunization program. And fun thing, yeah, this morning I had a chance to take a trolley for the city tour. It was great. San Diego is so beautiful. It's so different from Rhode Island. Yeah, I really enjoyed San Diego. Hopefully I want to visit here. I have more good times. Okay, anything?
Hello, everyone. My name is Mina Qobedi. I'm originally from Iran, but I live in Mississippi. I arrived here yesterday, so I have no idea. No, let's say this. I'm an epidemiologist, and I'm doctoral candidate in epidemiology in Jackson State University in Mississippi. I have no idea about the fun fact, but I can say that my hobby is driving and hiking, so that's it. Oh, oops.
Hi, everyone. My name is Erica LeCount. I'm originally from Miami, but I live in Milwaukee, Wisconsin. I'm the epidemiologist for the Family and Community Health division there. I oversee our vital statistics program and our fetal infant mortality review program. And a fun fact, this is my first time in San Diego, and I hate the cold and I live in Wisconsin.
Hi, I'm Mike Kenny. I'm the Title V analyst for the Vermont Department of Health. So I live in Burlington, Vermont, and well, I don't know. I can't think of a fun fact really, but
Good afternoon. My name is Judy Espinoza, and I'm an epidemiologist for the Albuquerque Area Southwest Tribal Epidemiology Center, and we call it Aztec, and that'll be the last time I'll say the whole name like that. I do a lot of work with the youth survey in New Mexico, and I have worked with PRAMs, but not as much. Our epidemiologist who is actually leaving us for our PhD program. And a fun fact is I'm a master composter.
Hi, everybody. My name is Kyra Brown, originally from Arkansas, coming from Wichita, Kansas, from the Sedgwick County Health Department. I'm a postdoctoral research associate there, and I lead different special maternal and child health projects, as well as analyze our county level data and evaluations for femur and Healthy Start in our Healthy Babies program. Fun fact, I love reggae music.
Good afternoon. My name is Ingrid Mburia. I am the epidemiologist for the MCH Title V program at the Division of Public and Behavioral Health in Nevada. I oversee data needs for the Title V program, the COIN program, and recently we just got awarded PRAMs, so I will be overseeing PRAMs. Other duties as assigned, my the Title V manager just recently underwent an open heart surgery, and so I'm taking on her role. Her boss stepped down soon after that, and I'm taking on her roles too. And on top of that, I am a PhD candidate trying to graduate at the end of the year. So as you can see, I do have a lot on my plate. Fun fact, I'm originally from Kenya, and I love to cook Kenyan food. Thank you.
My name is Alip Bamaraju. I'm the Quality Improvement Coordinator at the Cincinnati Health Department's Maternal Infant Health Division, and I'm a PhD student at University of Cincinnati in sociology. So my research interests are in race and reproduction. So I study like structural racism and how it affects the provision of reproductive health care services. And a fun fact about me, I also love reggae music, but the thing I'm gonna share is that I just got a new cat, a black cat. It's the first time I've ever had a cat. His name is Gigi, and I'm really missing him. But it's great to be here. Oh, I'm sorry. Over here.
Hello, everyone. I'm Karina Saraiva with the California Department of Public Health, MCH division. My area of focus is mainly to be more of a nutritional epidemiologist, so I focus on breastfeeding, food insecurity, maternal weight issues. I'm also one of the lead analysts on our MIHA survey, which is our version of PRAMS in California. Fun fact is I was born in Portugal, and I came here when I was 6.
Hi, I'm Ann Nakamura. I'm also with the California Department of Public Health, Maternal, Child, and Adolescent Health Epidemiology branch. I am mainly working on perinatal outcomes epidemiology, and I am the state's lead evaluator for our Black Infant Health Program. A fun fact is when I'm not working, I'm a ceramicist and potter.
Hi, everyone. My name is Leslie Ann Soto. I am epidemiologist at the MCH division of Puerto Rico Department of Health. I work basically with pediatric population. I analyze data related to femur, infant mortality, and latent causes of deaths, etc. And the fun thing is also that I hope to have some fun here at San Diego.
Hi everyone, I am Marianne Cruz, also from Puerto Rico. I am the epidemiologist of reproductive health, so I work with basically everything about women and pregnancy and the baby. And then I pass them to her, which works when the baby is 1 year old, it goes to her. And the fun fact, I am a mom of 2, and I am very happy and proud to be their mother.
Hi everyone, I'm Matt Turner. I'm from the Hawaii Department of Health in our Office of Planning, Program, and Policy Development. So I work on maternal and child health as well as various other areas. Fun fact is, no, I don't surf, so I can't tell you about that, but I do play ukulele. So.
Hello everyone, my name is Portavia Featherstone. I'm from South Carolina Department of Health and Environmental Control. I am a maternal and child health as well as a WIC epidemiologist. And fun fact is, let's see, I've only been operating in my position for 6 months.
Hi, I'm Kelly Hansen. I'm from the Oregon State Public Health Division in Portland, Oregon, and where I've been a long time, so welcome to Portland. I am the research analyst for oral health specifically, which is housed within MCH in our group, and this year I'll be running our SMILE survey, which we do every 5 years to look at caries rates around the state. Fun fact, I spent a lot of my outside time playing French horn in a bunch of different groups around town. Yeah.
Good afternoon. My name is Anne. I work as an MCHEPI at the City of Columbus Health Department in Ohio. I'm part of the Ohio Equity Institute as well as a local initiative to reduce Black infant mortality. This is kind of like a homecoming for me because I did undergrad and grad school here and my family's in Los Angeles, so it's perfect learning and family activity.
Hey everyone, my name is Bintu Marong and I'm from Washington State Department of Health. I am a maternal child health epi. I also am the lead evaluator for 2 grants, a grant out of ACF, which is the PrEP grant, and also another grant from OAH, PAF grant. We call it Enlace, so I evaluate 2 major grants. I also work on PRAMS. A fun fact is that I'm from Gambia. I think you guys can tell from my accent.
Hello, I'm Marie Samin. I am the epidemiologist with the Cincinnati Health Department. I'm working in environmental and also helping out with maternal and childhood health. And I'm also part of OEI and will be the co-lead for OEI, so I have lots to learn this week. and I am from Egypt and love to travel.
Hi everyone, my name is Ailey Joseph and I'm here from Public Health Seattle and King County up in Washington. At the county I do maternal and child health epidemiology. I'm a maternal child health epidemiologist, as well as I do a lot of the geospatial analysis for our unit. This is really great timing to be here because our county is doing the first ever child health survey to assess the needs of children between the ages of 1 and then when they get into school. So I'm really grateful to be here. The one fun fact about me, I guess, that I'll mention is that I'm originally from India, and so I've lived in a very hot climate. And then I moved to Seattle, and everyone's really freaking out this week because it went up to 90. And we don't have ACs in our homes. And it's just, I think it's interesting that I just got used to Seattle weather, and now that I'm here, I'm like, oh, this is perfect. So that's the fun fact about me. I'm just unused to heat anymore.
Good afternoon, everyone. My name is Florence Canoe. I am the Georgia PRAMS coordinator / epidemiologist. So I'm going to want to talk to all the PRAMS folks. I am originally from Houston, Texas. That's my fun fact. And I'm also a PhD student. Just finished my comp, so I'll be entering candidacy hopefully in the fall. Did I say everything? I think so.
Hi, I'm Beth Musser. I'm from the Virginia Department of Health, Office of Family Health Services, Department of Policy and Evaluation. I work primarily with genetic screening, newborn screening, birth defects, and Healthy Start. Fun facts, I like to read epigenetics books and research in my free time. And I recently got into Krav Maga, which is Israeli combat fighting.
Hey, my name is Elaine Broadway. I am from the Montana Department of Public Health. I'm the MCHEPI there, so I do COIN, birth records, oral health, WIC, you name it, I probably have my hand in it. I am from Montana originally. I got my PhD down at Emory, and I do love cold weather, so I was very excited to go back to Montana. It's not really a fun fact, but I'm a proud owner of 2 dogs, Tuki and Dobzhansky, and I miss them terribly. So if you want to... I would have loved to bring my dogs.
Hi, I'm Jenny Robertson. I'm from Salt Lake County Health Department in Salt Lake City, Utah. And there I'm an epi who does everything but infectious disease. So this is a new venture for us. And a piece of that was going to be maternal and child health, but I'm happy to say that we actually hired a full-time employee to just do maternal and child health. So I'll be working with this new individual doing this together, I think. Fun fact, I took my first Lyft ride today. I feel a little behind the times on that, but I survived.
Hi everyone, I'm Megan Young. I'm an MCHEPI at the Boston Public Health Commission, which is the Boston City Health Department. And I've been there for about 5 years now. And I'm the evaluator for the Healthy Start program there. Fun fact is I am training for my first half marathon in October, which is going to be out in Yosemite, which will be kind of fun after I get through the training.
Hi everybody, my name is Jana Goins. I'm the MCH epidemiologist at the Baltimore City Health Department. And so I spend a lot of my time supporting our Be More for Healthy Babies initiative, and that includes a lot of epi and data for various things. So vital stats, femur, PPOR, all that stuff. Fun fact, I'm trying to not be weird. Share something normal. So I'll share the weird thing. So I work out with this group called November Project. I don't know if you guys have heard of it. It's like a free fitness group, and they're in 30 different cities around the nation and in other countries as well. And so they have a group here and they are working out on Wednesday morning, and I think I'm going to go do that. So if anybody wants to come with me, it's at 6:30 a.m. I think it's in Balboa Park, and it's really fun. So,
hello, my name is Sonia Baeva. I am a maternal mortality epidemiologist at the Texas State Department of Health Services, and I work with maternal mortality. I support our state's maternal mortality task force. That's what I do. Fun fact is I like stand-up comedy and beer.
Hi, I'm Michelle Cormody. I'm also an epidemiologist with the Texas Department of State Health Services. I support mainly the Healthy Texas Babies Initiative and our infant mortality COIN team. Fun fact about me is that I have a twin sister. She's back in Austin right now watching my dog, and I miss them both.
Hi, I'm Melissa Cullen with the New York City Department of Health and Mental Hygiene. I'm a research scientist there in the Bureau of Children, Youth, and Families in the Division of Mental Hygiene, so I mostly focus on providing analytic support around early mental health as well as maternal depression. Fun fact about me is that I have 2 rescued pit bulls, and they cuddle with my cat.
Maybe we can all just like share dog pictures later because I really miss mine too. I'm Emily Mobile. I'm from the Louisiana Office of Public Health. I work for the Children's Special Health Services Program, which is our CYSHCN program. And my fun fact is that I paint children's murals on the side.
Hello, everyone. I'm Nicholas Pishka. I'm from the Los Angeles County Department of Public Health. And I primarily provide analytic support for a variety of things. A weird fun fact about me is I have a 18-month-old son, and I was coming out of the Whole Foods, and we were going to the parking lot, and I was singing to him, for those of you who had kids, like some Rafi song called Banana Boat. And I turned around, and Simon Cowell from American Idol was behind me. He got in the elevator, and he told me it was horrible. So, but it was worth it. So.
Hello, my name's Mira Sheff. I'm the state MCH epidemiologist in Minnesota. That also makes me the PI for PRAMS. Let's see. Interesting fact, I've only been in the job for about 9-10 months now. I was trained in environmental and occupational health. I got my PhD in that. And so MCH is a little bit of a new framework for me, so I'm really happy to be here. I moved from New York, Brooklyn, New York, to St. Paul, Minnesota for this job, and that was 2 months after I had my son, and I still suffer from pregnancy brain, so there you have it.
Hi, everyone. My name is Hannah Feldman. Welcome to San Diego. I actually am an epidemiologist for the County of San Diego, so it's nice to have so many fellow epidemiologists in town. I'm with First 5 San Diego, so we are tobacco tax, and all of our funding goes towards serving pregnant women and children who are 0 through 5 years of age. I've been with the county for maybe 2 years. Before that, I was doing a postdoc at UCSD looking at fetal alcohol spectrum disorders. A fun fact about me that would be beneficial for all of you to know is that I am a native San Diegan, so I left for about 10 years but came back maybe 8 years ago. So if you have any questions, I'm more than happy to help you out with finding out activities to do, or I do have friends that rock climb. I used to rock climb before I had children, so if you need to connect with some people, I'm happy to help out. So welcome.
Hi, my name's Emily Maureen Lozano. I'm a CSTE CDC Applied Epi Fellow in Augusta, Maine, at the Maine Center for Disease Control, not to be confused with the Federal Center for Disease Control, which is very confusing. So I do a lot of different work. If you're familiar with the fellowship or you did it, we do a lot of projects. I've done a lot of work with our Integrated Youth Health Survey so far. Fun fact, not that fun, but when I arrived here today, I couldn't figure out why the air felt so weird, and I realized there's no humidity here. And I'm from St. Louis, and I lived in Houston, so it's amazing. I love it.
Hey everyone, I'm Haley Cash. I'm a contractor for CDC, and I'm the non-communicable disease regional epidemiologist for the US affiliated Pacific Islands. So I work with Guam, Sinai, Palau, Marshall Islands, Federated States of Micronesia, and American Samoa. So I do a variety of projects in a variety of places. Fun fact, if you haven't figured it out, I really like to travel. And I'm usually in a constant state of jet lag.
Hi, I'm Benny Kandasamy. I'm with the Maternal and Child Health Bureau in the Office of Epidemiology and Research, and I'm an ARISE Fellow. I actually work for Ashley. And I do work with Title V data and some independent research and also some home visiting data. Interesting fact, I have absolutely no musical talent whatsoever, and I've tried many, many things, but I really love going to concerts so I can appreciate good music.
Hi everyone, I'm Lawrence Reed. I'm an epidemiologist and the director of the Office of MCHEPI for the Maryland Department of Health and Mental Hygiene. In that office we work on epidemiology analysis for child fatality reviews, maternal mortality reviews, PRAMs, use hospitalization data, and birth effects analysis, and soon I'll be managing the Zika pregnancy registry. Fun fact, recently I've graduated with my PhD from Hopkins Bloomberg School of Public Health. And for those that are aware of The Wire, the show The Wire, me and my wife were able to sneak on set during the filming, so my face was in a shot in the 5th season, so.
Hi, my name is Raquel Qualls-Hampton. I'm the epidemiologist and director for the Office of Surveillance, Epidemiology, and Evaluation at the Tennessee Department of Health in Nashville. I am, like my transplant friend here, just 8 months new in this position. Originally coming from Chicago, I am a PhD graduate from UIC, so I'm and I was in Texas for 8 years at the University of North Texas Health Science Center, where I was faculty. In my position, I have 3 surveillance systems in my office, PRAMS, BIRFIS, and the Tennessee Cancer Registry and Comprehensive Cancer Control Program. So I feel very schizophrenic sometimes between MCH, cancer, and chronic disease, but my love is MCH, so I'm here. Fun fact is, I have 3 children, and we are now at different ends of the United States. I'm in California, my son is in Denver, and my daughter is at an internship in Washington, D.C.
Hi, I'm Melissa Bruner. I work at the Indiana State Department of Health. I'm also an MCHEPI. I work with Title V, COIN, home visiting. We will be getting Medicaid data, so I'm really excited about that. Fun fact, I too like hiking and biking, and I tried to combine the 2 with mountain biking, and I don't think it's going to go very well. So.
Hi, I'm Chrissy Fiorentini. I work at the New York City Department of Health and Mental Hygiene in the Bureau of Maternal, Infant, and Reproductive Health. I primarily work with our 2 home visiting programs, also work a lot with biostatistics data, and I've recently started working with PRAMs because our coordinator just left, so I'm kind of filling in there. Fun fact, I really like baseball, and I'm excited to check out Petco Park when I'm in San Diego.
Hi, I'm Richard Chang. I work as a contractor with the Naval Health Research Center here in San Diego. I'm a data analyst, so working with a lot of the military health data populations. I run a lot of SAS. So I've been here in San Diego for just a little over a year now. I've been exploring the city a lot. I like taking pictures, and I recently became a level 3 contributor to Google Maps, whatever that means. It doesn't mean a lot, but yeah.
Hi, my name is Navjot Kaur. I like to go by Jyoti, and I am a colleague of Richard's. I also work at the Naval Health Research Center at the Department of Defense Birth and Infant Health Registry, so that's a mouthful too. And we work a lot with like vaccine studies and basically anything the DoD really wants us to take a look at. And I'm actually transitioning to a completely different job soon. It's going to be Epi in Kern County, so it's going to be totally different, going from research to more like the applied field. So I think this will be great to help me prepare for that, and also, help my team with projects I'm working on currently. And a fun fact about me is I've lived in San Diego for about 3 years, so I can also help answer questions, or if you guys need help like finding places to eat or whatever. And I've also started practicing Krav Maga for about a year and a half, so it's been really fun.
Hi everyone, I'm Kristen Larder. I work at the Michigan Department of Health and Human Services, just newly created department. And I've worked for almost 5 years on PRAMs. I now work with home visiting, and I worked with childhood led for a while. And let's see, fun fact about me is that, well, I just moved to outside of Ann Arbor, Michigan, from Lansing, and we also moved at work too. So we're in a new building, and so that past couple of weeks has been a little crazy for me, but I'm glad to be here.
Hi, I'm Bill Sappenfield. I'm professor and chair of the Department of Community and Family Health at University of South Florida College of Public Health. I'm director of the Child Center and also the director of the Florida Perinatal Quality Collaborative. And I work just about on any of those things. And fun fact about me, my wife really hates it. When I leave town, bad weather happens. Tropical storm Colin is hitting the coast of Florida while I'm enjoying myself here in San Diego. So she's not very happy.
Hi, I'm Kristen Rankin. I'm an assistant professor in the Division of Epidemiology and Biostatistics at the UIC School of Public Health. I was trained in MCHEPI, and now I get to teach MCHEPI, and I love it. I love the community. It's just such a great group, and I love to hear about all of your backgrounds and everything. A little fun fact about me. Well, I guess first I should say I work with our Illinois Title V program on applied epi analysis. My current area of research is more in like postpartum health, which you'll find out some about this week. And fun fact is that I have 3 little girls that I had to leave at home. 7, 5, I'm going to be 3 on Sunday, so I will be home for the big 3-year-old birthday, which is good. And I've been spending my time playing and coaching softball. I coach my 7-year-old now, and it's fun. It's interesting and it's fun.
Hello, everybody. I'm Maureen Fitzgerald, and I'm the Senior Coordinator for Logistics and Program at City Match, which is a national public health association focusing on urban maternal and child health. I've been there since 1997, a fact which Bill would know very well because at that time he was the CDC assignee to City Match and was on the interview team that hired me. Thank you. Thank you so much. Yeah. On a slightly different perspective or end of the spectrum from Kristen, I had to leave my 2 children at home alone too. One is 27 and one is 29.
Okay, so we're going to start the training portion now. Ashley, did you have anything else?
Well, I'm so glad that you're here. I've been doing MCH epidemiology for almost 33, 34 years. You have, in my opinion, one of the best, most fun jobs that you can ever have, where you can take your epi and data skills and really make a difference, a measurable difference in the lives of women, children, and families. and it's been absolutely a thrill for me. I started out at EIS at CDC and then was signed out to the Mississippi State Department of Health. Went from there to the South Carolina Department of Health and Environmental Control. Then up to City Match. I did do an early stint with the Massachusetts Department of Health. And then after I led the CDC program for MCH Epidemiology for about 4 years, at which this time this course actually evolved. And we worked in partnership with CDC and HRSA. And then I retired from CDC, went to work as a state MCH epidemiologist in Florida because what else would I want to do? Until the university came and asked me and said, now, wouldn't you like to come to the university and teach others to do what you do? And so it's been a fun and exciting time for me. Most of the different projects you've worked on, the different data sets, at some point in my career, I had the opportunity to do all those things. When I started, no one knew what MCH epidemiology was. It was not on the landmark. I was the first CDC career epidemiologist assigned out to the South Carolina Department of Health and Environmental Control when the MCH Epi program actually started to work in the assignees and from South CDC out in the States. So it's been a fun and evolving field. You are so lucky to have this sort of training. Boy, I can't tell you 30-something years ago how I would have loved to have this type of training instead of learning everything the hard way and from scratch. I'm going to spend today and tomorrow with you on a variety of topics. I'm going to start out talking about public health planning and the public health planning process. Now, you might say, why in the world is an MCH epidemiologist talking about planning? I promise you, when I took my master's, they didn't cover that topic. In fact, when I went to Harvard and got my degree, the MCH faculty who I know and loved and were friends for most of my career told me not to take any of the MCH courses. They said they were all out of date and would not meet what I needed to do, and encouraged me to take as many of the methods courses, thank you, as I could so that I would be in a better preparation, that I spent my time at CDC and out in other places that I would pick up MCH. And so most of what I've learned has been that way. One of the things I want to tell you is, as an MCH epidemiologist, in my opinion, you cannot be effective without understanding and utilizing the public health planning process. In fact, I would say that it's almost impossible that your evidence, data, research, review, synthesis, white papers would mean nothing if you don't engage in the public health planning process. Because that's where critical information is used to make decisions. And one of the biggest problems that we have frequently in state health departments, even today, is you have the data people over here, and you have the program people over here, and there's this wide gap in between, where the data people tend to understand what the data people do, and the program people understand what the program people do, but they don't work together and they don't work in an integrated fashion. And in doing that, you have limited ability for your data and research to have any difference. So I embrace the planning process because over my whole career, the most frustrating thing to do would be have a nice model Cadillac study that I would put on the shelf and no one read and use again. I have absolutely refused in the last 20 years in my career to be in that situation because I don't want my time wasted. There are too many problems in women and children and families to be addressed for me to go off and do a nice project that makes me look good, but makes no difference for women and children and families. It's just not going to happen. Now, it did happen. Even when I worked hard at it and did everything right to not have it happen, it happened. But I'm going to try and talk with you tomorrow morning about what you can do to try and address some of those pieces. Now, again, I don't want you to think I compromise my EPI principles, but I value my EPI principles and I want them used. It did work earlier. Okay, so, I hopefully I didn't do it bad. Okay, I'm going to do some clickers. Now, you have clickers in front of you. Hopefully they will work. And I may have messed up the first question. And if I did, I apologize. But I want to poll you guys. It's very simple. There's different letters on your clicker. And I have a question. How have you been involved in needs assessment? Never seen involved in needs assessment. Seen others involved but not participated. Contributed data and reports. Assisted in producing a needs assessment. And actively engaged in needs assessment. Or led one. Click your question. We're up to 34. There are no wrong answers, by the way. And no one knows what your answers are but you. Okay, show me the answers. There we go. Okay, so the most of you have actually contributed data reports. But a good number, a fifth of you, have actually engaged or led a needs assessment. And actually very few are you at this end. Very good. Which needs assessments have you participated in? I hope I did this right. I'll bet you I didn't. Choose the one you worked most in. You can change your answer. Choose the one you've worked the most in, because I'll bet you I didn't set this question up right. You can only have one answer. Sorry, I did this yesterday, and I'm still sort of recuperating. I got the summer flu, and so I wasn't sure I was going to actually make it. The block grant makes up for about half of it. The next largest amount is other. And then you have health improvement plan and none. So we'll know about Title V today. How effective was your LADS needs assessment in leading to sustainable impact? How effective was your last needs assessment in leading to sustainable impact? No visible impact, minimal impact, some impact, clear impact, substantial impact. I clicked you off too soon. None to some. For those who had impact, what did you find led to your needs assessment having impact? Yes, ma'am. What did you do that you think helped that needs assessment have sustainable impact?
The results went to the people that made the decision to change, to affect change.
Well, let me change that. The people you gave the results to used that data to affect change. And they had the power to do so. So they had the power to, and they chose to use it. Anybody else? Because some of you had some impact.
I'd say the same. So it's kind of in progress. The direction, but
Hopefully, it's always in progress.
yeah. So it was passed along to decision makers, and so at the community level, it's been recognized and through press release and that sort of thing. So it's getting there in terms of some impact.
Okay. Yes, ma'am. Aligning. Okay, so in other words, it's not the state defining what the locals do, but a collective process. Very good. Any others? Well, I want to talk some about some of those pieces. I want to acknowledge Mary People Sheps, Anita Farrell, and Mary Rogers. I use some of their materials religiously. I also did a lot of this work when I was at City Match when Maureen and I were together. So borrowed from Greg Alexander and Donna Peterson. And then I've been using it a lot when I was at the Florida Department of Health to try and refine some of this. Being effective in public health. I would challenge any of you to choose a time where public health has been effective, where we've not had effective planning. I'll say that again. I would choose you to identify a public health issue where we've been effective at addressing without effective public health planning. Why is that important? Because if you're going to be effective, You got to have a good planning process and be able to plug into that. And by that, we're talking about assessing your needs and your capacity, looking at your capacities and strategy, developing a plan, implementing, monitoring, evaluation. That seems very obvious. However, in most of my experiences, people's planning process was more like this. In other words, there were a lot of processes going on simultaneously that didn't necessarily have anything to do with each other. The needs assessment frequently got given to the data people because it was a data exercise. At the same time, the program people went off and tried to decide what it is they were going to do. And oh, by the way, the budget people said, well, we'll figure out what you come up with, and then we'll figure out if we'll fund it. And we only got around, we didn't monitor him because the feds required it. And also, we only did an evaluation if the grant actually literally required it, we do it for the money. Otherwise, we just didn't get around to it. If your planning process looks like this, how likely are you going to be effective? This is where you really have to change that paradigm. And I'm glad Title V is doing that. That it's not now as much about a data exercise as it about a prioritization of what it is we want to focus on. And the Bureau and others have worked very hard to change that. Because you can, in MCH, you can have a whole series of priorities. There are far more priorities for mothers and children and families to be done than there are resources, time, or commitment to do. The challenge gets to be is this gives you the impression that planning is linear. Well, I will tell you in my 30-something years, I've never had our planning process ever be linear. Most likely, I will tell you what frequently happens is we get money. And as soon as we get money, they want to know what we're going to do with it. And by the way, in a short period of time, we want you to show you the results of the money you gave you, because otherwise we wouldn't have given you the money to begin with. And we may not give it to you again. So all of a sudden, you're starting out at the plan, already have to figure out to show how you made a difference, and you haven't even started the process. The key to this is to remember what you're trying to do. Think of the planning process, in my mind, as an integrated. Frequently, we would get the money to do something. At the same time, we would figure out what were the best strategies, but we'd save some of our time and resources to go back to assess. In other words, yes, we'd do something with the money so we can keep getting the money, but we'd go back and start to assess our issues. We would review our capacity, and we would make sure our strategies were evidence-based. And any time you start a plan, you better know what you're monitoring and evaluating. So what we would do is we would just implement a comprehensive process. The idea is we may not start out picture perfect at the beginning, but eventually we would be going through all the steps to make sure we were well directed. In other words, if you know what it is you need to do, you may have to start at a different place, or you may have to start at multiple places. But if you keep the perspective of where you need to get in a planning process and getting everyone engaged and everyone on the same page with the most effective strategies, you need to think of it in an integrated fashion. Because the other thing I will tell you is you'll never get it right the first time. You'll never solve it. It's an ongoing process. I wish in MCH I could tell you the number of MCH problems we solved in my 30 years. I'm hoping you will do better in your career than we did in mine. We're still trying to deal with infant mortality. Now, infant mortality is half what it was when I started. In fact, it's about half. And we're still, the prematurity for the first time is starting to decrease. Maternal mortality, though, is flat, continues to be flat. So it's a variety of issues. So it's an ongoing process. So it's not like we have to get it done the first time. We need to be a learning, reshaping, evolving program based off the reasons we have. And this sort of process is there to do that. I'm going to give you an example back from the 80s. It's not that I'm old-fashioned, but it's a very simple example, and it's one we still haven't solved. We still have women who enter prenatal care late, who still don't get adequate number of visits. And this is many years later. But if you look here, this is data for South Carolina. South Carolina, white women are in the red. Black women are in the blue, going from 1983 to 1997. This right here is regional black women. What was discouraging in South Carolina was not only that we had the racial disparity, not only did we have women not accessing prenatal care, but even compared to other southeastern women, which is, by the way, not the benchmark for the United States, we were doing worse. That was unacceptable. We should be at least doing as well as Mississippi, Alabama, and Georgia. Okay? So we started to work in doing a needs assessment to address this problem. We identified 6 priority need areas. 1, we knew that we were underreporting prenatal visits on our birth certificate. Because our birth certificate was based off the medical record, not everything made in the medical record. You know, it's really tough to have women start prenatal care in the first trimester when doctors won't actually schedule the appointment to the second trimester. And they didn't see any need to appoint them earlier. And even though WIC is not supposed to have a waiting list, and we're supposed to always see those people immediately, we actually had late entry in our WIC prenatal program and saw how bad it was, and so we had our own internal problems. It's also hard to get the community to address an issue or embrace an issue. We just talked about a state, local capacity. If the community itself doesn't recognize the need for prenatal care to take place, and why does it make a difference? Transportation and child care continue to always be barriers that need to be dealt with, but the biggest thing that surprised us the most, and the strongest contributor that we could find in our data analysis and needs assessment, was unintended pregnancy. If the pregnancy was unintended, the likelihood of the mama starting prenatal care late was more than 2 to 3-fold. Part of that was the women who have high unintended pregnancy rate are high social risk, but part of it is they don't immediately go get services. And our prenatal services and our family planning services are not connected. One of the things you're going to hear about me is I have beefs. One of my pet issues that I worry about is we're still talking about prenatal, family planning, preconception. It's time that we just talk about women's health services. We should not have a system that women go in and out of. We should have a continuous system that meets the needs of women of where they are. But however, we keep talking about how we have patient-centered care, but in fact, we still provide provider-centered care. You go to the provider who provides the care you want, not that our services are arranged around what patients need at the time they need it. So it really takes a whole process. So we had these 6 problems. We identified all of them as priority. We charged 6 different groups to review our capacity and look at potential strategies. I'm just going to give you one, typical epidemiologist. I'm going to talk about data reporting. We had underreporting of prenatal visits. First, we had just moved to the electronic birth certificate. Most of you have electronic birth certificate. It doesn't seem remarkable, but when I started, none had it. And still some in the last 10 years finally got it. But they had been doing the electronic birth certificate for almost 3 or 4 years, and guess what? They never changed the vital registry manual. It didn't even tell them how they completed the electronic birth certificate. It just was the same thing. Well, it's kind of hard to give somebody a book and say, follow this, when it doesn't even align with the system upon which you're putting your data in. And that also meant we didn't have any comprehensive training that went along with it. So they actually knew what they were doing and why they were doing it. We actually had one of the first healthy starts. In our first 2 years, we actually discovered prenatal care got remarkably worse. Does anyone want to take a guess as to why it got remarkably worse? Any guesses? Oh, that would be nice. No, it wasn't that smart. Anything else? There was a regional center where most of the babies were born, and the registered person decided that 7 was the right number of prenatal visits. And all of a sudden, on most birth certificates, reported 7 visits. Because she made that fundamental change, and we could tell when she made the change, our prenatal care participation changed radically. Now, the sad part is, if she had chose 10, we never would have discovered it. Even if it was the same number of visits, you would think we'd discover it, but our systems weren't that sophisticated. But she chose 7. It made the rates bad. And the hospital changed their whole system around because they knew Healthy Start was important and that we needed to capture it. But that just shows you how training is important. The health department didn't always get the prenatal record to the hospital. Well, they counted the number of visits on the hospital form. Well, if you don't get the records, you count fewer visits. Some hospitals decided the health department really wasn't a medical record. So even when we sent them the prenatal record, they didn't include it because it wasn't really a medical record. There was not a standardized prenatal form. So if you look at the forms and people switch between providers, and they do in prenatal care, it was very hard to figure out your visits. Physicians in hospitals had no idea what was going on and why it's important. They were not educated. We didn't get back to people in our monthly reporting. We report your rates every year. So if your rates got really worse or really better, you didn't find out till almost 9 months after that year. And so it was irrelevant data. There were no hospital standards and no incentive. So we identified some of the areas that we thought within our capacity, in our resources that we could address, and we also felt like there were effective ways to do it and we could make a difference. We did the same process with all 6 of our priorities. We continued the process of working on the plans, reporting it regularly, monitoring the situation. And what we discovered was we did have a large improvement in prenatal visits. However, we noticed so did the rest of the region. So did our efforts really make a difference? Were others doing similar pieces? But we did feel good that some of that gap started to decline. But then if you think about this from the planning cycle, I told you we never fixed things right the first time. Back in 1983, Medicaid was fixed to welfare, and we could be on Medicaid at 23% of poverty. We raised it in 1987 to 100%. In 1989, we raised it to 185% and decoupled it from Medicaid, from welfare. Then, starting in about 92 to 93, we actually raised reimbursement for the provider, so we were paying them twice as much to do it. The health department started to become the entry point on the Medicaid and getting women into prenatal care and then getting them ready to go out to the private sector for care. We started to coordinate our services, and then we started to see our improvement. The point I'm trying to make is the idea of a planning process and to solve a complex issue like this is not going to happen early. It points out that you got to affect the system at multiple levels, not just with Medicaid, not just with ACA. You can't assume that coverage fixes a problem, but it takes a multifocal process over time to create change. So, when we start talking about needs assessment in the planning process, who's accountable? One of the hardest things that I've been trying to work with MCH programs, by the way, I've been doing, ever since over 89, I've been involved in needs assessment, either leading it for a state, consulting with a state, or participating in a state for every single cycle since then. And we've been working very, very hard to change this concept of ownership and who should own it. And the idea is it's not about needs assessment being something that's done every 5 years and who gets involved in the needs assessment. It's about the who, what, when, how, and where about the whole process. I want to know who's going to own the results 5 years later. Who do you need to have at the table to have the results that you need. I want to design a process where there's accountability throughout this. So even though the Bureau might say you're required to do this every 5 years, I might be doing actually ongoing assessment, capacity, and planning throughout the whole process. The worst thing is when someone starts to talk about the needs assessment, and I'm going to assign the needs assessment out to the data unit, I'm going to assign the plan out to the planning people, and then no one's accountable. The key is who's going to be accountable and who am I going to be feeding to make the right decisions at each one of the stages. Does that make sense? And if you can't define that process, then you won't succeed. My most favorite example was I was consulting with a health department on doing needs assessment. I got through doing this, and they go, oh, well, that's great on paper, but we can't do that. We don't have time to. What's the problem with that response? But why to go do it, except for the feds require it, so you got to turn something in. And by the way, there's some people, that's exactly what they've done. They've turned something in. How else are you going to become less busy if you don't plan? If you don't figure out what your priorities are, guess what you're always going to be? Overly busy. So if you don't have time to figure out what your priorities are and what you're going to focus on and how you're going to be accountable, then how will you ever be accountable? How will you ever figure out what you're supposed to be doing and spending time on it? So why doesn't it happen? One is there's just no political will. The leadership is just not interested in change. Everything's fine. The feds have never not funded a state through MCH block grant dollars. I'll say that again. The feds have never, the only few reasons that you cannot get funded by the feds is you can't build roads and you can't build buildings. But if you don't violate any of the financial rules, the rest is really up to the state. Now, you may get papered to death and you may get conditioned, but bottom line is you're going to get your money. So the problem gets to be is you really have to have people who want to use a planning process and a needs assessment to do what's best for moms and babies. Without that political will, you're almost dead. Competing priorities or desires. I have other things I want to do right now. My most favorite thing is we just went through this needs assessment process. We really embraced it. We got it all done. And as soon as we got it done, the MCH director said, well, now that you got that done, Bill, come over to my office. I have these other priorities I want you to work on. It's like, wait a minute, didn't we just decide what our priorities were? Lack of accountability. No one feels that responsibility that 5 years later, something is going to be different. And that if it's not changing in that 5-year period, I'm going to do something differently. Lack of commitment over time. Most plans lose steam if there's not leadership to hold accountability. Insufficient resources to actually do what needs to happen. Limited planning expertise. How many of you have been in a planning process that has failed? Come on, guys. All right? Part of it gets to be is some people think that you're born in your genetic code with planning ability. Or that it's common sense and that everybody knows how to plan. Well, I've now been a professor for a while, and I must tell you guys, not everybody knows, especially the department chair, how to plan. It is a limited expertise. And then you experience other failures, and so you sort of go into these plans with what I call a failure mentality. And so the key is you need to change that paradigm. So why is it important to epidemiologists? Or why? One, you're part of the MCH team. You're the foci for contributing data expertise. You provide common priorities. In fact, our division director said every office or division had to have a strategic plan. And I immediately walked into her office and said, I can't do our strategic plan until I know what all the other divisions are doing. Because my role in the office is not to go off and do my own thing. The role in my office is that we work collectively on something and that I provide the data and the evaluation and expertise to do it. And that my focus ought to be based off of where we think the priorities are. You need to be involved because it provides a common language or framework. So when you're talking to a program person, you know how to relate. It does lead to data-driven decision. And it assists in translating those findings to actions because you've been doing it together and people know why you're doing it and you have your results. The epidemiologist needs to be part of the team, but I would argue most of the time, unless you have a lot of experience in leading this, the MCH epidemiologist should not be the lead for the needs assessment. Because what ends up happening is you're then the lead for the plan. The lead for the plan needs to be the stakeholders who are in charge, and your role is to provide a service to that group with the expertise that you have. That just gives you a context on planning. Questions about the planning cycle? Does that make sense? I'll talk a little bit more about it tomorrow. What I want to do now is go a little bit into needs assessment. This year, since you all just finished your Title V needs assessments, we decided not to spend the full gamut of the whole needs assessment. We're just going to focus on the first part. But normally we do it as a two-parter. We're going to talk about problem identification and prioritization because that's a skill that most of you as epidemiologists are not familiar with, and we have some tools that might be useful. So what's the definition of a needs assessment? It's a systematic collection and examination of information to assess and prioritize the needs. Wrong button. To make decisions to formulate a plan. For next steps leading to public health action. So the bottom thing that I want to tell you is your needs assessment needs to lead to action. It's a foreign concept to data number generators. But if your numbers are not leading to actions, then you've not helped them. Those actions are to make decisions related to a plan. So the idea is you can't just do a needs assessment on its own. It's got to fit in to the next step. It goes back to that integrated process I talked about. You just don't do needs assessment on your own. It's got to fit into your capacity, your strategies, and your planning. And they need to be done in such a way that one fits the other. You wouldn't run a relay race if you didn't know how to hand off the baton. The same with your planning process. You need to be able to know how you connect. What are some of the qualities of a needs assessment? One of the things you'll notice, I don't have a cookie cutter for how you do a needs assessment. A needs assessment needs to be tailored to the process, the people, the resources, and where you are. And there are a variety of methods depending on what the needs are. But it needs to be conceptual. You need to have a scientific framework or theory or public health approach to base your needs assessment on, whether it's MAP or some other approach, but it needs to be a conceptual basis for what you're doing. It needs to be visionary. We used to do a quiz. So what's the difference between needs assessment and evaluation? You know what? Most people treat them the same. You know why? Because the needs assessment is required every 5 years. They don't do the evaluation, so they think evaluation is, in fact, needs assessment. Okay? And they're separate. Evaluations tend to look back to see the results of what you're doing. Needs assessment is trying to look forward as to what you need to be doing. So it's more than evaluation. Now, the problem gets to be is if you haven't been doing evaluation in a needs assessment, you might find yourself needing to do evaluation so that you can look forward. But it's not about evaluation. It is about that looking forward process. Now, the other problem, though, I will tell you is I tend to sometimes be too much of a forward thinker and a visionary. In one of our needs assessment, before we had the National Survey for Children with Special Health Care Needs, we actually did our own survey of families. We identified 6 marker conditions. We identified every mother and family in the state of a child who had those different special needs. And we went ahead and did phone or in-person interviews with almost 900 families. And we did this under the blessing of the special needs director because that's where she thought we needed to go. I met over the needs assessment questions to say, these are the things you need to know. Is this what you're looking for? Yes, and she gave input in those pieces. But what happened by the time we got through the end of the needs assessment, I gave her the results, she goes, well, Bill, this is really important. There's a huge number of needs. But we're actually not ready to go there yet. We really still got to figure out our clinic services, and we haven't figured that out yet. And I'm looking at her. We spent 2 years on this survey. It was probably one of the more comprehensive ones in the state, in the nation. And she's now saying we just should have focused on clinical services. And I'm going, well, I ended up not leaving because of this, but I ended up moving on. 5 years later, though, she actually pulled out that needs assessment, and they were ready. So the idea is I need to be thinking to the future, but I need to make sure that all of us are thinking the same range into the future. Why do I bring that up? Someone says, well, Bill, what do I do? The MCH director wants to do a title needs fee assessment because HRSA says we've got to do one. But all they really want to do is continue to do what they're doing. And I'm just supposed to put on paper what they're needing to justify what we're doing. So what should we do in that situation? I'm a pragmatist. Every state has gotten their block grant dollars. So my needs assessment focused in on the realm of what we're doing, how what we need to be doing needs to be better in better shape for the future. And are there gaps that we're missing that we need to be focusing in on? We may not be ready now, but what I call incubators for the future, because most initiatives you can't just stop doing this and start doing this. It's a time sequence process. So we changed our needs assessment to focus within the parameters of what our charge was. So I want to understand, when I say visionary, I mean it really is not what you think the future holds, but it's what the program and the stakeholders all together think the future needs to hold. And your needs assessment should be guiding to make the best decisions in that framework. Does that make sense? It needs to be systematic, resourceful, pragmatic. Those are obvious words. The last two are foreign concepts. It needs to be action-oriented. Most people say data, action-oriented. If your data is not done in a process in a way that leads to everybody working together on some common priorities, have you succeeded in the needs assessment? It cannot lead to analysis paralysis. You cannot be stumped by the data and say, I don't really know the answers. You need to know the best answers you have given the situation you have, or you may actually need a plan to improve the data so that you can have better data as part of that plan. But it also needs to be done in a way that it's cohesive. You don't want to do your needs assessment in a way that by the time you finished, you fragmented your stakeholders. Because how likely are you going to be effective if everybody or most people are not embracing what you prioritize? You're not going to get very far. There are a variety of different types of needs assessments. You may focus on a community. You may focus on Title V, which is a population. A health system like an emergency response assessment. You might do a program like Title X. You might do health services like where you're going to put your clinics or how you're going to operate them. Or you might focus on a health problem, something like infant mortality. But my experience with most needs assessments, you can break them down really into 2 steps. One is you want to do a health problem identification and measurement. And you want to prioritize those health problems. And then part 2, you want to analyze those health problems so that you better understand them, so that you can link it to better stress your strategies and your capacity. You understand, again, part of it is identification, prioritization, but part of it is better understanding your problems. Of these 2, which is most important if you want to be effective? How many think number 1 is the most important? How many think number 2 is effective, important? How many are lost? I will argue that most states and most places spend 90% of their energy here. Again, I would argue that there's so many priorities and issues for mothers and children. If we would just collectively choose a few and address some of them, we'd be better off. The biggest problem in my viewpoint is right here. We may come away and decide our priority is teen pregnancy. If we do not understand what's going on with teen pregnancy in our state and where we are and what are the issues and what are the strategies and which of the effective strategies are we doing, we don't dig into the problem. How effective are we going to be at addressing teen pregnancy? So the biggest problem is everyone spends 90% of their time and energy, because this is what the feds require, and little time here. And if anything, I would tell you, you needed to reverse that. And that's over years of experience. So let's talk about health problem identification and measurement. What makes something a health problem? Ideas. What makes something a health problem? I'm actually expecting answers. Something that negatively affects an individual's health. So some sort of health outcome. And it could be in a subpopulation. What else makes something a health problem? Oh, a grant. Money. Money makes something all of a sudden a health problem. So it could be the cost of that health problem, the overall population impact.
So in my experience, sometimes it's somebody in power who feels they have had a problem, and therefore it is now your priority to address.
Oh, when somebody in charge or someone of high authority says, this is our problem, and we're now going to work on it. Florence. How many people it's affecting? I would call those all parameters on deciding what is a priority. But when you talk about what is a health problem, one of the things I want you to realize is this a measurement or is this a value? One of the things I want to throw out to you is health problems are values. We personally, we collectively decide what is important and what not is important. We decide what is a health problem and what is not a health problem. I can go into parts of Africa and talk about infant mortality, and they would never consider infant mortality a problem, even though it's one of the highest rates in the world. Why? It happens all the time, so we have a lot of babies. So the key is, what are the values that you think are important? You might say, well, Bill, that means it could be anything. It could be a community perception. I mean, how many have been part of a community group? And you ask community what a priority is, and how many will tell you cancer is? A couple, but most of them will not. You know what they'll tell you? Safe neighborhoods. I don't have good lighting. I have dangerous areas. I have no walkable paths. So part of what a health problem is, it's a community perception of what they perceive to be a health problem. And it may actually not be what us public health types who get money and grants think that it is. It may be a health status measure. It may be a risk factor. It may be the lack of health services. It may be some measurement that makes something a problem, or it may be some comparison that one group is worse than another. But I want you to come down with the idea that we're really getting down to choosing values. And unless you come away with that understanding, you're going to think that I can put everything on the same scale. You might decide I can cost everything out on a population basis, and the one that costs, or the one that's most cost beneficial, is the one I should do. But what is that saying about my value? My value is money. That may be a rational value, but does everybody at your table who's a stakeholder agree with that value? You understand where I'm coming from? So when we start choosing priorities, we need to realize it's not just about the numbers, it's not just about the measurement, it's about capturing the values that people have and what is important and what is not important. Because we can show you time and again where you can give different examples, and people will choose different priorities even though the data is the same, because they have different attachment to certain problems than they do other problems. So as soon as you start to realize it's a value judgment, when I start to prioritize, I need to start putting the human factor into this. In other words, needs assessment and prioritization is not just a data effort. It is a human effort to work through the values of what we as a society or as a group of stakeholders believe was important. So most of the time what we encourage you, your first step is to go through problem identification and verification. So you'll go to your stakeholders and your partners, and you may survey and focus people. You may do public hearings or town hall meetings. You may do reports, availables. You may well get other needs assessment. But what you're trying to do is get out there to see what do people think is important? What are they value? What are they doing? I call it basically a search and compile. That's why the federal government will talk about your need to engage community and the need to get public input. The whole idea is you're trying to figure out what do people value. Once I have all the problems, then I try to go through what I call problem definition. Because I can't just say something is a problem. I want to know what is the extent, what's the duration, expected future course of that problem. Is there variation or disparity? Is there an impact that I need to be aware of? I also need to think about what my prioritization criteria might be so that I would actually make sure that I'm getting the data that would help with prioritization. I call it define, describe, and validate. And I would use stakeholder input to make sure that I've captured what they were saying with the best available information. And then I would go through a group process. Remember some of those qualities. I said I wanted something that was action-oriented and that was cohesive. So if we're going to now come back and choose our priorities, we need to decide how. We need to decide who. And that who gets to be important. Is this going to be a stakeholder decision? I've been in the agency where the clear message was from on high that the head of the agency will actually decide what the priorities are. So in this decision-making process, how do I include stakeholders when the boss says that they're going to decide? The key is the boss is going to decide. It doesn't mean we can't do recommendations. And so the one time we were in that situation, we pulled the stakeholders together, and guess what we did? We told them the truth. We're going to go through this identification and prioritization, and we're going to make our recommendation to the commissioner, surgeon general, our secretary, whatever you call the title, and then they're going to use that as input. Okay? But they were okay with that because they knew. The worst thing, though, to be is to pull a group of stakeholders together and go through a prioritization process, not informing the decision's going to be made up the chain of command, and all of a sudden, what comes out is not the same as what you recommended. So integrity in the process is important, but there are some different processes. One is group consensus. Can anyone tell me what I mean when I say group consensus? What does that mean? That everybody agrees. Strong personality wins, everybody agrees. What else does a consensus mean? The idea of a consensus is not that everyone votes yes, because you can never get everyone to vote 100% yes. The idea of consensus is that the group will come to a decision and everyone is willing to support the decision. Does not mean that everyone agrees, but that everyone supports. You may have vocal people in the group, but the group still has to have support from everybody. Now, in an MCH needs assessment, and your stakeholders, how likely can you come away with consensus? What? It depends on the size of your stakeholder group. Most of our stakeholder groups, once you talk about MCH, tends to be very broad. Yours may be small. Kelly, you may get away with that. Ours are usually easily a dozen or more. And consensus is very hard because we have people come into that group who come from one organization or one program, and they have one focus in mind. And so it's hard to get what I call consensus. The next is voting, and majority wins. Now, what's the problem with consensus building or voting? How do people feel when their issues voted down? They're not happy. How many walk away with, I'm ready to work on this? How many show some commitment, at least to you, on the face value of what you've decided if they just get voted up and voted down? It makes it come away as a popularity contest. Consensus is hard because what do you do if you can't get consensus? And if you told the group up front, we're going to run by consensus, you can't just all of a sudden say, well, this isn't working, we're going to switch. So you've got to decide. So what I'm going to talk about is criteria-based rating and Q sorting. Does these sound familiar, or are these new terms? These are group process tools to help you select values and do it in a priorities perspective. And we're going to walk you through some. Now, hopefully everyone got the exercise in advance, and hopefully you got a chance to look at the data, because I'm now going to put you to work. You're actually trying to prioritize some of these data things that I already gave you as a sample. So hopefully you have those, and they're available or they're in your packet. I magically gave you 9 categories. That's because in these processes, it works out the best for an example. But I came up with some. Most of these come off of different people's needs assessments, but hopefully you'll have those. Now, they're handing out paper copies for those who just happen to need the paper copy of it. And those are coming out. But Q-sort. Q-sort is a process that most people don't know about. Q-sort uses some special rating processes that work. In Q-sort, what you basically are going to do is have people rank one thing first, 2 things second, 3 things third, 4 things fourth, 5 things fifth, and then downward. So instead of just ranking top to bottom, which I don't know if you've ever done, is extremely hard, you really only do that at the wings, but you can write more things in the middle if you choose. Can anyone tell me why this may be advantageous? Why would I go through something as complex as this pyramid? One is it's easier to rank, by the way, if you've never done this, because ranking to me is hard. So is this 7th or is this 8th? I don't know, it might be 6th. I mean, it's really hard in that middle group. But why would you do this? It actually has a stronger discriminating function than a regular ranking system. Because you go what you want to do and what you don't want to do, it pulls more things out. So you have greater contrast in what is important and what's not. Do you know why this is important in MCH? When we get together with program people and we try to choose priorities, we were always looking up here. And our scale never went very high, high, medium, low, very low. It went extra super high, really high, very high, high, and occasionally something would reach medium. We would never have anything below medium. Does that sound familiar? Nothing in MCH is not important. This one actually forces you to say, who am I going to vote off the island? In other words, it's just as important that I have a number 9th as number 1. So it starts saying in a needs assessment, what do I not need to be doing, or doing much less of, as well as what I need to be doing more of. And that's a very important function because it's very hard in public health to give something up. For your exercise, there are going to be 9 categories: 1 first, 2 seconds, 3 thirds, 2 fourths, and 1 fifth. And in the exercise, I'm going to walk out how you rank those. Yes. Yes. Okay, that list of 9 things that I showed you. This list of 9 things. You've got 9 of these. I'm going to ask you to come give me 1 top ranking, 2 second rankings, 3 third rankings, 2 fourth rankings, and 1 fifth. Does that make? Yes, ma'am. Your question's all over your face. It's very different from voting, and I'll describe why. It is a type of voting, no question. Any of these things, you're going to be trying to decide on values. So if you think about deciding on values as a form of voting, the answer is yes. But the key is the process I'm using more likely to lead to some agreement, cohesiveness, and potential for action, or am I going to polarize the group? So what you're trying to do is choose a group process that has more validity by the group and more ownership by the group, that they may feel more comfortable. And we're simply voting up and down, it tends to negate ownership. If yours gets voted in, great. If it doesn't vote out, I'm out of here. Again, 1, 2, 3, 4, and 5. Now, on the criteria side, the idea here is, instead of just trying to rank from top to bottom, I want to use some value-based criteria. I want to be clear. I'm now going to put on paper and get the group to agree on what are our values in deciding. Okay, now you could say these are quantifiable, Bill, and that's correct. But just because it's quantifiable doesn't mean it's not a value. The reason I say that is not everybody may agree with every criteria. What's the magnitude of the problem? What's the trend? Severity or consequences? Perceived preventability? Is it a national state goal? In other words, is it a blessed priority by everybody? Is there agency capacity to deal with it? Is it politically and community acceptable? If the governor says, we're not going to deal with this issue, guess what? It's not politically acceptable. So, but the difference here, instead of voting something in or out or ranking something in or out, I'm now going to have you assign scores. Or for some of these, I might assign to somebody else because they're quantified variables to actually just give them scores. Now be careful. Just because I'm using a value criteria doesn't mean everybody at the table is not going to use other criteria in their head. They still can play the game. Sorry, guys. You may know this, but people rig numbers for a long time now. And even though you're using a criteria process, they still may choose to rig some of the numbers. They may worry about personal preferences or state and agency agenda or what they're currently doing in the programming, I don't want to do anything different. Or a grant, I'm funded, this is what we need to do. It fits in with what our staff currently do and not what needs to be done. People are available to work on the issue. Art strokes the heart. So even though you have these explicit criteria, just be careful. People may still try to fudge the numbers. And that's part of that value-based decision making. Now, so here are the criteria. I use them as example. You could say, but Bill, magnitude of the problem or severity of the problem is far more important than acceptable. Believe it or not, I've been in every decision-making process. Everybody has their own thoughts. If you think one of these criteria count more than others, you can actually assign weight to that criteria so that you give it more value. It's easy to do. Spreadsheets make this an easy process. The other thing is, you don't just tell them rank it from 1 to 5. You might actually give them some express criteria. So for magnitude, it might be a low incidence or prevalence. Low incidence, but moderate in some subgroups. Moderate in all groups. High in some subgroups, but moderate to low, or high in all groups. So you might, to help them not fudge as much, you might actually give them categories upon which to rank. Or rate, I'm sorry. You might use some common outcome metrics. We're epidemiologists, of course we'd use common outcome metrics. Be careful, again, if the group doesn't see that as a value, that may not be a good step, even though that's what you're trained to do. They may use mortality, or hospitalizations, or potential years lost, or costs or dollars, or population attributable risk. They may try to put them all on some scale. The positive of this is it can be quantified. The negative of it is if the stakeholders don't buy into it, don't go there. Again, the stakeholders have to make the decision. If they don't agree with this sort of process and you go into it, then what does your process lose? It loses its credibility. You can use magnitude and such. So you get your scores. So you can take each of these, low birth weight, perinatal HIV, maternal smoking. You can score them all out. You can go from the weights and go from here and multiply them together to figure out what the score is. And you can come up with a combined score at the bottom. And so you're using that to be more of a criteria-based that everyone's contributing to. Again, you have your 9 problems. They fit all the way across. Again, I'm not going to put weights, so you can skip the weights today. Of the time I've been doing this, and I have had different groups, I had one group who started out with weights, and then when they actually had to come up with the numbers and discuss it, they finally said, stop. We just won't weight it. Because it was hard to get agreement on what was equal and what was different. But it's a possibility. Okay, the problem with identification or prioritization and the challenges. Lack of commitment to new priorities. They only want to focus on what's old. Getting consensus support for selected priorities. Really bad. Do not go into an unclear decision-making process. As soon as the process of deciding is unclear, you will have no ownership. Special agendas, selecting too many priorities. I've been doing this for many years in block grants, and it's been very, very hard to get people not to choose a few priorities. Not this last cycle, but a cycle before last, I was finally in a state where we had a choice between 7 and 10 priorities, and guess what? We turned in 8. I was so proud of them. But they finally got it. If we didn't have the resources, we shouldn't be prioritizing, or we wouldn't do anything. The other problem gets to be is, I don't want to vote anything off. So what they do at the last minute is, well, we have these other 3, but they're really similar. We'll just bunch them together and call it one priority. So not only do they have 10, they really actually have 16, because they clumped everything together to make sure everything was still there. How good does that work? Again, how do you decide what is a priority? The way I try to say it is, if you can have one simple strategic plan that focuses in on it, it's one priority. If you have to have 3 different strategic plans to make it work, or 3 components of a strategic plan, then it's not one priority. That drove people bananas, but that's what we pushed, and it worked. I don't want to finish without saying it. This whole thing about needs assessment, it's not about coming out with an answer here. It's about enabling this next group to have ownership, cohesion, and the information they need to make the best decisions for the next step. And you need to realize of all the things you do in the needs assessment, that is probably the most important thing. Again, we're not going to talk about part 2, but again, I want to say that that's an extremely important part that needs to be there. Questions? Yes, ma'am.
I have a question. So in practice regarding the weight
Uh-huh.
process, is that something that's collectively decided with the group?
Right. If you're going to use weighting, how do you decide? The group who's going to make the decision needs to decide the weights. Why? Because the whole idea is that people who need to make the decisions need to have faith in the process, and the process needs to lead to a decision that they can support. If they feel like somebody else is now telling them how they're going to make the decision, they're not going to find it as their decision. Does that make sense? That's why that group gave up waiting it. Because once they figured out they figured I didn't make that much difference, they finally gave it up. But it is there. Other questions? Yes, sir.
Could you, do you think it would be too complicated, or could you Q sort the weights? Get them to rank what they have.
There are a lot of different ways you can do it. The biggest thing is, I would tell people is, I don't know about you, how many people really like planning processes? And how many like to really struggle with it in their community groups? Keep it simple. The more complex you make it, something complex doesn't mean they're going to buy into it. In fact, I will tell you that most groups, the more complex it is, the more of a black box it is, and the less they buy into it. Now, you could do some voting processes, and you could do some other processes to decide. So, Michael, yes, the idea of figuring out a group process that could come up with those weights is helpful, but they got to believe in them. Other questions? Okay, what we're going to do now is I want to give you time to go through and take those 9 priorities that hopefully you reviewed and look over them and do your own prioritization with both methods. And I'm going to try and keep track of you because I want to give you some of the results that the methods give you at the end. So I don't want to just leave you with just the exercise. I want you to see the results. And if you have any questions, don't hesitate to raise your hand. I'll be happy to try and answer them. And sometimes the instructions aren't clear. Let me know. I'll be happy to explain them to you. always this question on the rating. Your rating from 1 to 5. You can actually have priorities rate exactly the same. So no, you're not ranking the priorities there. You're rating them just between 1 and 5 for each of those criteria. So the highest for the rating based is 5, 5, 5, 5, 5. The lowest is 1, 1, 1, 1, 1. But other priorities can use those same numbers in any mix that you think is appropriate. Does that make sense? It's not a ranking, it's a rating. 1 to 5 versus the ranking, it's more different. One of the questions was, when one of the ratings says national or state goal, and we don't tell you what the state goals are. So feel free to just use your own state's priorities and goals if that would make it easier for you. One of the scales that's having problems for people is this severity scale. The idea of severity would be, at one end you could say is mortality, or you could, at that end you could say extreme disability to something less. The idea behind that is, for example, maternal mortality, you could say is extreme severity, but its magnitude is small. Where unintended pregnancy, the severity of outcomes may not be as large, but the magnitude is much larger. Does that make? So you're trying to factor in both severity as well as magnitude. This may be where you get in debate on how much you weight one over the other. That's something for the group to decide. But both are trying to be in there. Hope that helps. One person said, well, does cost represent severity? Well, obviously, something severe is leading to higher cost if it has higher cost. So yes, you could think of cost as fitting into that perspective of severity. I'm going to give you just a few more minutes, and then we'll get started, because I know most people have gotten into both, and that's all that's important, is you have some experience with both. why don't we go ahead and get started? I know some of you haven't finished, and believe it or not, some of you have finished a while ago. And so we have the spectrum. Each of us go through this differently. But I want to try to capture some of your experiences. Okay, these were the 9 priorities that you were looking at. Did you find the data package useful? Fairly concise, a good way to quickly look at a lot of data. The idea is that's very important as you try to go through a prioritization process, that you have some data, no matter what method you use, to help make sure people are somewhat grounded with what's going on. So let's go through this. So what are you trying to do through this selection process? Again, I want to emphasize, these are all values. You think about them as priorities, but you're essentially trying to help the group come to a value judgment. And to be successful in the end, you need most of those stakeholders to be committed, if it's a block grant, for the next 5 years. So you need to keep them engaged in some way. So you're trying to build cohesion in the process. You're trying to make sure it seems fair, equitable, everyone has an opportunity to participate and express, so that they feel like their issues are covered well, so that you have credibility. And you want it to lead to a decision that people can support. Because you certainly don't want to finish your selection and have a group start trying to submarine you. So again, in your Q sort, you went through the ranking. Happened to be 1 through 5, but that's only because we had 9 problems for you to review. These are the results from last year's group. Last year's group was the advanced group, so we may not have gotten the same results. But instead of trying to compile all these numbers quickly with this group, I'm just going to use last year's group. Remember, in Q sort, the lower the score, the higher the selection. Remember, number 1 is high, 5 is low. Smoking during pregnancy, teen birth rate, infant breastfeeding for 6 months were the 3 highest. The lowest were childhood motor vehicle deaths, adolescent suicides, children's health insurance. The key gets to be, though, one of them said, how is this different from voting? Isn't all of this voting? Wasn't that your question? The key is, now I don't have just votes, I have a scale. And not only do I have a scale, I can then analyze the group. This tells me how many respondents were in each of the category. What can you tell from this? What can you tell? Well, 1, health insurance wasn't very important. But how important was it to about a 5th of the group? Okay, your lowest scoring priority was important to a 5th of the group. Do you think that's important to know? Do you think that's important to recognize? Do you think that has to be dealt with? All right, so even though I have this rating here, not only do I have an average score, I can now see where do people decide? Because remember, when it was 1, it was their single 1. And when it was 5, it was their single 5. So we're talking about polarization here. Look at teen birth rate. Again, we got about a bulk of the group here, but we still have almost 1/4 of the group saying it's the highest priority. So what does this help you? It helps you, it's not just about the average. Remember, in epidemiology, they told you it's about the distribution. And in fact, if you remember averages don't mean much if it's not a very symmetrical distribution. And so you need to be very careful at doing that. So knowing where people are disagreeing is a helpful process. So what did you think about this whole idea? You all just went through it. What did you like about Q sort? Did you like anything? Yes, ma'am. You didn't take anybody. You didn't take state and federal priorities. You could just choose what you thought was important. What? Yes. It was really going to the individual. What really mattered to you? Now, you may have had data, but really goes heavily on values. Each one matters. Each issue matters. You got to put it someplace. What? It was quick. Well, for you, it was really quick. Let's be clear, because you may not have used as much the data as everybody else did. They may have focused more on the data.
Once I figured out my highest and lowest priorities, everything else was easy because I didn't have to push it away.
How hard was it to figure out your lowest priority?
You know, not as hard as my highest one.
Your highest was the hardest. Did any of you have problems with picking out the lowest one? It's hard to say, you're not important. We're going to vote you off the island. So how do you handle that with this group? Are they voted off the island? So everyone's votes, and they're not bound to anybody, and they can show how they value. How about, let's say that if unintended pregnancy is voted as a low priority issue, does that mean you're going to give the feds back your Title $10? No. So the other thing, to be very clear with the stakeholders, just because it's not a high priority doesn't mean our department's going to stop doing it. If we got funding from the state to do birth defect surveillance, guess what we're going to do? Or if we got a grant from PRAMS, we're going to keep doing those things. What it means is, where are we going to take most of our energy and most of our extra resources and thought and focus? Doesn't mean we want the other things to drop off. Doesn't mean we want them to stop. It doesn't mean we want them to be poor quality. It means that's not where we're going to spend most of our leadership time and energy, making sure we're doing the most advanced things that we can do to affect the population. So it's going to be very important when you start voting things off that people don't realize that you're meaning stop. Now, some things you may vote off. In fact, you may ultimately decide, yes, we just need to stop. But that's not done simply on this voting. Does that make sense? Other thoughts about experience?
It helped me to think about how important it was, also how satisfied I am in what's being done right now.
Oh, so not just how important, but how satisfied are you?
I think it's a good tool for sort of a diverse audience in the sense of you're not one dominating voice, it allows equal voice.
It has an equal voice, and it's not dominated by any one individual. That's very good. What did you not like about Q sorting? Well, the nice thing in a tribe process is you may already have a decision-making process, and I would intuitively take care of the decision-making process that they normally do. However, I would argue they're probably not used to either of the more advanced processes, and I think the advanced processes lead to a better group process and decision-making. So you're probably going to have to teach them, Judith, either of them. So, but it may be different. So you're going to have to take some time to walk through it. I will tell you, with most Native populations I need, they won't like the criteria-based at all, because they will feel very limited. very defined by somebody else's value judgments. So my gut feeling says they're going to like Q-sort a whole lot better than criteria-based, but you could prove me wrong.
I think it all depends on how well I explain.
And they have to decide on it.
Yeah, beforehand.
Yes.
To build on that, working with similar populations, I was struggling as well because, I think we all have data brains and we're used to digesting all this information and ranking based on all of these data that we see. And I was trying to think how I would use that. I would have to do a lot more to help with it data interpretation before even getting to the point.
Well, we're going to come back to this discussion in the wrap-up, but yes, we'll come back to that one. Yes, ma'am.
Be careful with this because we have different data stewards for some of these different data sets.
Say again?
We have different data stewards.
Different data sets.
The data sets.
Right.
Also, different program staff assigned to different priorities, and their intuition is just going to be what I view as the most important, and nothing else matters. And I think it might end up being evenly distributed among
That one of the problems with Q sorting is you're not defining or limiting anybody to decide what is a priority. So it's a strength, but it is also a weakness. People come in with a predefined preference or value, then they can just put it in there. So that is one of the strengths but weaknesses of the process. Other weaknesses. But there is no justification. It's just what the group decides. It can be hard to explain to other people. So, in the priorities of questions, we made it simple. I limited it to 5 criteria so that we can do this in a manageable perspective. We did the sorting out. Now, here, high is high and low is low. Smoking during pregnancy was number 1. Child motor vehicle accidents was number 2. Teen birth weight was number 3. And at the bottom, child oral health, transition, and childhood asthma. Again, I don't look at their individual scores, but what I do instead was I look at their interquartile distribution. What does it mean to have a wide interquartile distribution? Interquartile, does everyone know what that is? That takes the distance between the 25th percentile and the 75th percentile. It's a dispersion measure. And what it tells me is, what does this mean for child health insurance if it's got a 5 versus smoking that's got a 2? It means there's a wide level of disagreement here, and there's less disagreement here. So again, it gives me some understanding of the distribution that I can compare across indicators. If you look at scores, it gets to be hard because there's numbers, and there's high numbers and low numbers, and the dispersion's hard to look at. But interquartile range. So if you have wide ranges down here, those are areas where the group is not in agreement that you may need to discuss. So what did you think about the criteria-based scoring? What were its strengths? What? It was explicit. You knew exactly how it was supposed to be selected. Be clear. How it was supposed to be selected doesn't mean that's actually what they followed. Yes, ma'am. We're now, what?
Yeah, I was going to provide a counterpoint to that. It was really easy to ignore the data.
You could.
I'm sorry, that wasn't a...
That's that what I call real criteria or hidden criteria. You can game the numbers. No question about it. However, it's harder to game the numbers. People find it harder to game the numbers in criteria-based than they do in Q sorting. Doesn't mean it's not as easy. People just find it intellectually harder to do. And their highest priority seems to get scored really high anyway. What else did you like about criteria-based?
you have a lot more control over like where people will prioritize things, right? So it's like if your interest is in getting some outcome, then like this is like a system that would allow you.
If you're very measurement oriented, you're very quantifiable, very rational decision making, this works well. And most epidemiologists fit in that category. Someone else had something?
Oh, I was going to say, I think counselor, so when we're talking about sort of the ambiguity of Q-score, I like that this would be easily facilitated. So like when I asked you about the severity question and being able to articulate that, okay, this is what you may need to consider with this, and having that facilitate the.
And you can even make scales that are more explicit so it's very clear. Which one was easier? I mean, it's the criteria-based one can really wear out your group. And if you have 9 criteria and 40 priorities, they're going to hate you. More importantly, they're not going to do it. The response rate is low, and the completion rate is low the more criteria you have and the more priorities you have. Because it takes a lot more effort. Other weaknesses, other thoughts.
I think that if you don't have the data, but it's a perceived problem, and it's one of those things that's not recorded or it's not on your birth certificate or something like that, there's no way to put that in here.
So what do you do when you have a priority and you have lousy data? It's a big question. However, the scale is such you could use your impressions. However, is that a fair way to do it? That would have to be a discussion of the group. Generally, if you don't have good data, it's a lower priority. Generally, because without good data, it's hard to score those things. However, this criteria does allow you not to have everything quite on the same scale. When I say magnitude, I'm not telling you exactly the units. When I'm talking about severity, I'm not talking about the units. So it has some ability to morph beyond exact measurement. But it still has a problem if you don't have any data at all.
This is just a question, but like, so in the situation where you do have a lot of priorities and, you're sort of trying to get some kind of consensus, would you recommend an approach which is a conjunction of both of them? Like you start.
We're going to go to that discussion. Hold that question. Yes, ma'am. That would be good. The biggest thing I want to caution you, though, is don't clump. Because even though they're related, it doesn't solve. The number of people say, well, if I work on infant mortality, that means I can work on teen pregnancy. Well, if you look at the contribution of teen pregnancy and infant mortality, it is really small. So be careful when you lateralize like that. And that's part of that training that you need to do. Now, let's look at something. Our processes don't come up with the same answers. Now, I did flip the criteria based, so low is best. So smoking in pregnancy was #1 in both. Teen birth rate ended up being very close. Infant breastfeeding, but look at child oral health. Look at transition for special needs, childhood asthma. Motor vehicle, look at the extreme. Almost opposite ends of the spectrum. Adolescent suicide, child health insurance. What does this tell us? What does this mean? You have the same data. You went through a decision-making process and you come up with different decisions. What does that mean? It is an art, but not a science. Very good. You want to expand on that? I wouldn't say they're completely different, but you're going to get somewhat different results. And that's because there are different foundations upon which you're making your value judgment. As an epidemiologist, I want you to know it's all the same data, but I can still come up with different conclusions. Why? They are different values. So if you walk away with anything, one of the things as I started out in epidemiology, I thought everything could be quantified. You cannot quantify values. And it just was this way. And if I don't value something as a high priority, how well am I going to succeed? Okay? So this value concept is really important. So which one is right? Is there a right answer? This shows you that your two different processes can actually lead to different value judgments.
But couldn't you argue that criteria-based score is more likely to give you the correct answer because you're being forced to think more deeply?
That's a good question, Ali. What makes something a right answer?
I guess your criteria.
I'll go back. Is it your, well, if there's no criteria, then you obviously know which one's right. However, does it make it right? The key is I'm trying to build cohesion and action to work on an MCH issue. The right answer is, can I choose priorities that I can get people to commit to for 5 years to make a difference? It's less on what the answer is than it is the commitment by leadership and stakeholders and others to hang in there and do something different. It'll go back to the premise that I told you is we have a whole lot of MCH health issues in the United States. You compare us to any developed country, guess where we rank? We're almost always at the bottom. So the key is not which one of those is more important. It's which one of those can we collectively commit to working on in our state, in our context, in our situation to make a difference. If I got a governor who's against it, guess what? I would not encourage you to choose that as a priority, okay? So, I mean, you understand what I'm trying to get at? There is no wrong answer. The wrong answer is to walk out of this with polarization, non-ownership, and making it a paper process of what got stuck to the feds. Because that means nothing is different going to happen for mom and children. Okay? So the key in this right answer, remember, is the commitment. Because who would you say that, would any of you in here say none of these are issues? Wouldn't any of you like to see almost any of these solved? Do you understand what I'm trying to get at? So whether worried about something was 1 or 4, it doesn't matter. Now the other thing is, does Bill Sappenfield say you absolutely use the high scoring and say it's my highest priority? That's the next thing I want to tell you is, I don't make either process be my decision maker. I use these scores to help start the discussion that needs to happen. Because remember, I've got a 4th or a 5th of people who totally disagree that something's a high priority. So the first thing I say is, okay, guys, we have this list. This is where we talk for discussion. First thing, some things didn't rate highly. Did we miss something? Does someone want to talk to us about what we missed in this priorities that we should listen to? And so we allow minority comment to talk about where we may have missed the boat. And do we need to adjust our scoring based off of those thoughts? And if the group agrees we should change its ranking, what do you think we do? We change it. Then we do the opposite. We'll come back and say, this ranked really high. Is there something we're missing here? Is this really something we shouldn't do? In one of our states, we voted down child health insurance. It was 3rd on the list. You know why? Our agency deals with child health access, but not child health coverage. Our governor was not interested in expanding Medicaid, not even trying to have people enroll in Medicaid or MCHEP or anything else. Our agency was told we cannot work on that issue. That's another agency's responsibility. So, do you think even though we ranked it highly, we should make that one of our priorities? We sunk it. However, on the score, it did well. So what we do is we use this as a point of discussion because you're trying to get the stakeholders to come to a decision, not to play some game. Do you notice how I don't pull a whole lot of punches here? I have this bad habit of just telling what I think is true. And luckily, I've kept my job so far. But no, I am known for just saying, look, I say it politically correctly. I said, right, if I can't use the governor's name, I said, you just need to realize there's not state leadership support for this. Right now, they've given this responsibility to another agency. So we have no efforts addressing this. Is this where we want to spend our time and resources? I'm always pretty good at stating things. I will state it, but I will state it in a way that I can get away with it and people can hear. Does that make sense? Again, I use my data and science to support the art of a decision-making process. Does that make sense? So the key is, I don't want you to walk out of here and say, this is supposed to tell us our final decision. This gives us a point for discussion. And what do we think? And I promise you, some will go up, some will go down, but by the time we get to the end, people are in agreement and supportive. Because that's what makes for a right answer. Okay? Now, are some people unhappy? Yes. But we have not attacked the credibility of the process. We have not attacked the trust of the process. So they may not have won, but they can't say they didn't have a chance to give data. They can't say they didn't have a chance to express their opinion. Clearly, the group didn't agree on that. Now, one of the next questions gets to be, talk through that. So we talked about how to use results. One of the questions is, can I combine some of these processes? The answer is yes, this is a decision-making process, and you need to figure out what works in making a decision. The other thing, though, I go back to Michael's comment, though, is keep it simple, doable, and something they trust. They don't want games. So and the other problem gets to be is there's limited resources. So in our state, the MCH director turned to me. I was working with a program director, and we co-led the planning process and needs assessment. And in there, but she said, you have no really extra resources to do this. So we started our identification process, and we came up with 86, 88 health priorities that we should consider. Well, I looked at their staffing. We cannot do a defining and measurement and description of 88 health problems. I don't know about your MCHEPI staff and your program staff. We don't have that much capacity. So what we did is we used the stakeholders and we voted. I don't like voting, but we're just trying to clean some off. And we voted down to 20-something priorities so that we could then write up the decision type of things that you saw Illinois use here. Thanks to Deb Rosenbook, we have that packet, and I really appreciate Deb sharing that with us. She walked us through this exercise one of the years. But we tried to restrict the resources, and then we went to criteria-based. But that was because the group decided that was the right choice. So how do you decide? Do I use consensus? Do I use Q-sort? Do I use criteria-based? Do I do something else? How do you decide which one you do? Which one's right? You have choices. You need to know your group who's making the decision. So you need to figure out the tool and approaches that will work with that group. You need to have one where they have confidence in the process and they'll use it in helping accept what the decision is. Why do I say that is there is not a uniform best approach for any one group. I had a former boss when I was at City Match, and she hated criteria-based needs assessment. She's the type of person who didn't want to stay in the lines. She didn't want to be boxed in and curtailed by what she thought she wanted to express and what was important. She just couldn't go there. So she absolutely wanted Q-sort. So which one do you think I wanted? I'm an epidemiologist. You got to quantify it. Of course I want the criteria one. You need to know your group. Some groups will, frankly, do better with Q-sort. Some will do much better with criteria-based. But I would also say you need to walk through these approaches and have the group help decide what you're using. Because for you to impose a process on them that they don't consider acceptable is a good way to what? Walk away with no commitment. Okay? So again, the key to this is the right answer is a commitment for change. And whatever you're doing, you need to be in a process that you have that commitment for change. And needs assessment needs to lead to that. So when you talk about this unit doing the needs assessment over here, this other group doing planning over here, that's a guaranteed failure before you even get started. So the key is how do we get that group going and how do we have all those people decided? Questions, comments? As an epidemiologist, I thought that was fabulous because I could just tell them what the data said. You know what I discovered? That may not be a bad idea. Give them the opportunity to change if they disagree with the ranking. The problem gets to be if they feel like I'm gerrymandering the decision, the confidence disappears. But if the group says, yes, we got an epidemiologist, I don't want to have to do this, please, Ann, do it for me, the answer is, I'd be happy to. And as you heard from my decision, I would probably never try to do criteria-based ranking on 100 of them. That would not, I couldn't do it, let alone most of the people I work with. Other questions, comments?
Is this a tool, are these tools that you would use to, so not to choose new priorities, but to look at existing priorities and reorganize them?
You can't, even if you take your existing priorities, you still have too many. Your leadership can't deal with all of them. So yes, I can do this as a more narrow needs assessment or a wider needs assessment.
What if the results come out and the priorities are things that we don't have a lot of funding or
That's why you have your discussion after your votes. And remember, something can be a priority, but that priority doesn't mean you commit a lot of resources. It could be, you know what, on the next 5 years, we know we need to do something here, but we have no idea what it is. We're going to use that as a development time. So we're not going to put it as a priority, but we're going to commit some resources so we're better prepared next time around. I mean, there's a lot of choices, but the idea is the discussion. It's not about the scoring. Well, we're about out of time, so I'm going to turn it over to others, and I'd be happy to talk with you all further.
The data or any kinds of.
You and I can talk afterwards. We're out of time. I apologize.
Okay, thanks so much, Bill. I think everybody probably got a lot out of this, as they usually do, from hearing Bill talk about all of his experience with needs assessments. So this is great. We are going to do a group activity, but I'm going to give you a little bit of a break first. But before we break, I would like to, well, first, just to let you know that there is a reception afterwards at 6 o'clock on the sun deck, which you can access from the 4th floor. So just to keep that in mind in case, like, when we break later, there's not a good time to say that. Second of all, I'm going to give you a little break here, but before you break, I would like you to just kind of get all of your stuff together because you're going to be moving around. And I'm also going to have you count off really old school to 10 to put you in teams of 4. So basically, we're going to count off. Remember your number, and then when you come back, 1, 2, 3, 4, 5 will be on this side, 6, 7, 8, 9, 10 on that side. And if you guys could just stagger yourselves, so 4 of you, group 1 is on this side of the table, group 2 on that side, and the second row. Do you see what I mean? So you have a little bit of space. Okay, and make sure you bring your name tags with you and bring them back tomorrow, because it is really nice for us as trainers and we can call on you by name. So any questions before we count off? And then you will have about a 6-minute break, and then come back here and I'll explain the instructions, okay? So you want to start here, just 1, 2, 6, 1, 2, yeah. Okay, great. Remember your number. Oh, 3, and one of the staff or faculty member. Olivia? The last 4 people are a group. Okay, sorry about that. You two there and the gentleman who just left and Olivia, you'll be a group. You'll be a group 11, okay? So you can use that last table back there. Okay, so when you come back, bring all your stuff. You don't need your computers out. So just come back to your table and we'll start in about 5 minutes. Okay, thanks. Oh, okay, can you leave the clickers at the desk and we'll collect those, right? Okay. Thank you. Okay, so now I need to... No, you don't need any materials for it. So you can pack everything up and just, you're probably going to need the table space, so you don't want to. Oh, is that Bill's?
Yes.
Yeah, let's switch back so he can take this. I'm sorry, I didn't realize this was his. Yes, but nothing that needs to be recorded. Is that the question, or is?